Welcome to the Deep Dive. We're here to give you that shortcut to serious knowledge. And today, we're tackling a subject that's, well, it's as baffling as it is tragic. Factitious disorder. This deep dive is built entirely from the clinical density of a key chapter in Kaplan and Sadock's comprehensive textbook of psychiatry. We're focusing squarely on a patient population whose primary activity really is deception.
Yeah, it's a heavy one.
Our mission here is to kind of move past the sensationalism you sometimes hear about and really understand the genuine clinical and psychological frameworks, the ones needed to diagnose and manage a condition where patients actively and often quite dangerously manufacture or fake illness.
Right.
We really need to understand that paradox. Why would someone go to such lengths to be sick?
And that paradox really is the hook, isn't it? Factitious disorder is the simulation, induction, or aggravation of illness specifically to receive medical attention. And the key driver, the absolute core of it, is the need for the attention and care that comes with occupying the patient role. It's not necessarily about being ill, it's about being seen as ill.
That is such a crucial clinical separation. Because we often hear the term malingering.
Well, at the time.
But that's different. Malingering requires seeking an obvious external reward like avoiding military duty, maybe getting a financial settlement, or trying to get prescription drugs.
Exactly.
But if the main reward is purely psychological, that identity of being a patient, then we are firmly in the territory of factitious disorder.
Precisely. And, while the reward is psychological, the consequences are intensely physical. They can be devastating.
How severe are we talking?
Well, the severity of factitious disorder can lead to massive morbidity, significant long-term health problems, and even death. The source material details some really harrowing cases, like an operating room technician, interestingly, the daughter of a physician, who repeatedly injected herself with non-sterile substances, specifically Pseudomonas bacteria.
Wow.
Yeah, and that led to recurrent sepsis, eventually bilateral renal failure, and it was ultimately fatal. It just highlights the genuine danger involved when this artifice of illness becomes chronic.
Okay, let's unpack the terminology then so you know exactly what the diagnostic landscape looks like. Factitious just means artificial or false, basically. And the DSM-5 and ICD-11 recognize two main types. First, there's factitious disorder imposed on self.
Right.
That's the individual presenting themselves as sick, impaired, or injured. This is kind of the classic image, maybe the self-harming deceiver.
And the second type is factitious disorder imposed on another. This is often, though not always, a caregiver, typically a parent, presenting another person, very often a preverbal infant or maybe a dependent adult, as ill.
And the source is very clear on this point.
Absolutely. Across the U.S., this is legally defined as child abuse, elder abuse, or abuse of a vulnerable dependent. And the safety of that victim, well, it has to be the absolute clinical and legal priority, no question.
Right. And just for context, technically, the nosology now places factitious disorders alongside somatic symptom and related disorders in DSM-5.
Correct.
But when people talk about those really chronic flamboyant cases, the ones you hear stories about, they're usually talking about Munchausen syndrome. That term was coined back in 1951.
Yeah, Munchausen is the severe, chronic, and often refractory form. It actually makes up only about 10% of all factitious cases, believe it or not.
Only 10%.
Only about 10%. And it's really distinguished by two dramatic features that make these patients almost, well, mythical figures in some medical centers.
Okay, what are they?
The first is pseudologia fantastica.
Which is?
It's the telling of these vague, untruthful, often really self-aggrandizing tales. Stories of past heroic illnesses or incredible careers, things like that. Usually there's a small kernel of truth buried in there, which lends it some plausibility.
Makes it harder to dismiss immediately.
Exactly. And the second feature is peregrination.
Peregrination. That sounds like wandering.
It is. It's the tendency to travel widely, often across state lines or even international borders, going from hospital to hospital. They used to have this, well, dated, but kind of illustrative nickname, hospital hobos.
Okay, so if that extreme chronic type is only 10%, what about the other 90%?
Right. The other 90% fall into what's often just called common factitious disorder. This patient profile is typically younger, often female, usually socially engaged, employed, and interestingly, quite frequently works in healthcare. Nursing is a profession that comes up in the source material.
That is interesting.
Yeah, and their illness behavior is usually confined to one medical center or clinic. They lack that wide-ranging peregrination you see in Munchausen.
Okay. To give you a sense of the history here, the source actually takes us way back. Galen back in the 2nd century, wrote about patients simulating symptoms.
It's been around.
And much later, in the 1890s, Jean-Marie Charcot describes something called mania operativa activa. It was a case of a girl persistently seeking surgery, which actually led to an unnecessary amputation. So this desire for, physical intervention isn't new.
Not at all. And what's fascinating about how the psychiatric criteria evolved is how we move from focusing on sort of the why, the motivation, to focusing more on the behavior itself. So when Roy Meadow coined Munchausen syndrome by proxy back in 1977, he really formalized that concept of external abuse through fabricating illness in someone else.
Right, but that term's been replaced now.
Yes, today that term is officially replaced by factitious disorder imposed on another. It's clearer.
And critically, DSM-5 dropped that requirement for clinicians to have to prove the illness induction was conscious or intentional.
Yeah.
That must have been hard to prove.
Extremely difficult. So the diagnostic focus now is strictly on the observable behavior, proof of deception. That's the key. In the absence of a clear external reward, that's sufficient for the diagnosis.
Okay, proof of deception, no obvious external gain.
That's the core.
Yeah.
And this really helps clinicians navigate that extremely blurry line with malingering. Because think about it. If a factitious patient is in the hospital, maybe they get free housing for a bit, or maybe they get a mild opioid for some reported pain. How do you sort out if that's malingering, which is QC30 and ICD-11, or factitious disorder?
That's a really good question. If someone is getting painkillers during a hospital stay, doesn't that blur the line right back toward malingering? How does the clinician figure out the primary motivation?
It comes down to clinical judgment, really. The clinician has to assess the preponderance of the motivation, what seems to be driving the behavior most strongly. So if the individual is actively seeking out really painful procedures, risking their life, maybe abandoning substantial financial gain just to stay in the hospital, well, the motivation looks clearly psychological then, doesn't it? The primary goal seems to be the sick role itself.
Okay. So even if there are minor secondary gains, the overall pattern points elsewhere.
Exactly. And while the two conditions, malingering and factitious disorder, they can and frequently do coexist, the absence of that clear major material gain is what steers the diagnosis toward factitious disorder.
Right. Let's talk a bit more about who these patients are. The prevalence is estimated low, maybe around 1%, but you said it's likely underestimated.
Almost certainly underestimated. It's hard to catch by its very nature. The profile for imposed on self tends to be predominantly female, mean age somewhere around 34, and as we mentioned, often a high rate of medical employment.
But the classic Munchausen profile is different.
Yes, again, that classic chronic Munchausen patient is often older, predominantly male, typically unemployed, unmarried, and frequently shows significant antisocial or maybe narcissistic personality traits, a different picture.
Okay, so those are the clinical facts, but understanding the underlying psychology, that seems critical. What are the main theories trying to explain this drive for what looks like self-destruction?
Well, the chapter highlights two main underlying factors for factitious disorder imposed on self. First, there's often an affinity for the medical system. These individuals are often medically trained or drawn to healthcare careers. They understand the system.
And second?
Second, they tend to have poor maladaptive coping skills. This is often symptomatic of an underlying personality disorder, borderline, narcissistic, dependent, sometimes antisocial personality disorder features are seen.
And this is where we get into the core psychological theories, right? Trying to explain the why.
Exactly. This is where we get to the insight that maybe the physical self-destruction is, in a strange way, a defense mechanism. It's as if these patients would rather deal with intense physical pain they can control than profound psychological pain they cannot.
Okay, so let's start with the mastery theory. What's that about?
The mastery theory suggests that the factitious behavior is basically an attempt to achieve control over situations where they felt utterly helpless as a child.
Like maybe during a traumatic childhood illness.
Precisely. Or maybe abuse or neglect. So by demanding invasive procedures or maybe dramatically leaving against medical advice, they seize control of the narrative. They take charge of the medical system itself in a way. They control the pain rather than the pain controlling them.
That makes a certain kind of sense, turning passive suffering into active drama, where they're the director.
You could put it that way. They're orchestrating it.
Okay, what about the other major theory mentioned? Masochism.
Masochism theory suggests that the repetitive endurance of painful surgeries and procedures is a form of repetition compulsion.
Repeating past trauma.
Exactly. They might be unconsciously reliving childhood physical or emotional abuse, but this time through the medical system. The medical personnel become these new, maybe ambivalent parental figures, and the painful procedures become a bizarre mechanism for attachment, even if that attachment is negative or based on suffering. They find a strange comfort in that familiar cycle of suffering and then being cared for.
Wow, and ultimately this behavior provides them with a role, doesn't it? The sick role.
Yes, it gives them an identity, a purpose. They become, as the source puts it, the masterful orchestrators of medical drama. They use their fabricated stories, that pseudologia, fantastica, as we talked about, to construct this desirable identity centered on being a survivor, maybe, or some kind of medical marvel.
Okay, so that helps explain the internal drivers for the imposed on self type. But what transforms that internal need into something so, frankly, lethal, the imposition of illness onto a dependent, like a child?
That's the really disturbing question. The source describes factitious disorder imposed on another as a kind of perversion of mothering, or caregiving more generally.
A perversion of mothering. How so?
Well, the child, or the dependent person, is essentially used as almost like a fetishized object to meet the perpetrator's own dependency needs. The mother, for instance, might use the child's fabricated illness to seek attention and validation for herself. Often it's about using the child to establish an intense, maybe overly dependent relationship with the physician, sometimes seeking a substitute relationship if, say, a spouse is uninvolved.
Is there overlap between the types? Like, do perpetrators of imposed on another also sometimes have imposed on self?
Yes, there's significant comorbidity. The source notes that about 10% to 30% of perpetrating mothers have a history of factitious disorder imposed on self themselves. So that pattern of seeking attention through illness is already there.
Okay. Because the danger to the victim and often to the patient themselves is so incredibly high, diagnosis really has to be actively pursued, doesn't it?
Absolutely, you can't just wait for it to become obvious.
Suspicion should be triggered when symptoms just don't make sense, when they defy conventional medical understanding. What are some of those clues that should trigger suspicion? The source lays them out, right?
It does. You need to look for symptoms that are inconsistent with known pathology or lab results that are just illogical, they don't fit. Other classic behaviors include the patient, say, refusing access to old medical records or not letting you talk to previous doctors or family members, collateral information.
They guard their story.
Exactly. They might show an unusual eagerness for really invasive procedures or surgeries, and maybe the biggest telltale sign: their symptoms mysteriously get worse right before a scheduled discharge. The goal is clearly the hospital stay itself, not getting better and going home.
And the methods they use to fabricate illness, I mean, they can be truly elaborate and clinically really challenging to spot. Can we review a couple of those diagnostic smoking guns? Like, how do they fake a fever or sepsis?
Sure, fevers can be faked simply by manipulating thermometers, heating them up, shaking them down incorrectly, or, more dangerously, by ingesting substances like thyroid hormone to actually induce a fever. When they induce sepsis or bacteremia, it often involves injecting contaminated substances, saliva, feces, non-sterile water. A huge red flag for clinicians is finding polymicrobial bacteremia, meaning multiple types of bacteria in the blood at once. Natural sepsis rarely involves that. It suggests direct inoculation.
Okay. And what about hypoglycemia? That can be lethal pretty quickly. How do they fake that, and how can clinicians catch it?
They might inject insulin or take oral hypoglycemic pills they shouldn't be taking, but clinicians have a fantastic diagnostic tool here, a lab test.
What's the test?
Well, when your body naturally produces insulin in the pancreas, it also produces an equimolar amount of another molecule called C-peptide. Think of it like a factory receipt that comes with the insulin. So, if a patient is injecting external insulin, the lab test will show high insulin levels, sure, but the C-peptide level will be inappropriately low relative to the insulin. It confirms the insulin didn't come from their own pancreas. It's a really elegant way to confirm external administration.
That's clever. But diagnosis must get even trickier when they're feigning psychological symptoms, right? Like false bereavement or pretending to have psychosis. There are no objective lab markers for that.
It's definitely harder. You have to rely more on clinical observation and inconsistencies. You look for symptoms that are, well, bizarrely specific or maybe culturally inappropriate, things that just don't fit neatly into any known diagnostic category. For example, the source describes a patient who reported seeing only the cast members of a specific popular television show emerging from her closet. That's just, well, it's far too neat and specific for genuine psychosis, which is usually much more fragmented and less tailored.
They overact the part, maybe.
Sometimes. Or they might readily admit to additional complex symptoms simply upon your suggestion. A genuinely psychotic patient often guards their delusions more carefully. They don't just add symptoms because the doctor mentioned them.
Okay, now, given the severe risk to children imposed on other cases, the source mentions a gold standard for diagnosis, but it's legally and ethically very complex. Covert video surveillance.
Yes, CVS. It's really only pursued after extensive consultation with legal counsel and hospital bioethics committees. It's a last resort. But sometimes it's the only definitive way to capture the perpetrator actively causing harm, whether that's through poisoning, suffocating the child briefly, or administering dangerous substances when they think no one is watching.
A very serious measure for a very serious situation.
Okay, let's shift to differential diagnosis. How do clinicians separate factitious disorder from other conditions that might look similar, especially those non-deceptive somatic conditions? Making that distinction between deception and genuine distress, it seems absolutely crucial. It is the crux of it. First, and this is vital, the clinician must always rule out genuine organic illness. Comorbidity is really common. A patient with factitious disorder might also have cancer or diabetes or some other real condition. They might be fabricating additional symptoms on top of it or aggravating the existing illness, so you can't dismiss everything.
Okay, don't throw the baby out with the bathwater.
Exactly. Then you need to separate it from two key non-deceptive conditions. First is somatic symptom disorder, or SSD. In SSD, the patient experiences genuine, often excessive distress from their physical symptoms. They worry intensely about them, but crucially, they are not lying. There is no evidence of deception. Their suffering is real, even if the physical cause isn't clear.
No deception. Got it. And the other one?
The other key one is functional neurologic symptom disorder, or FND, previously called conversion disorder. Here you see neurological symptoms like paralysis, blindness, seizures that are inconsistent with known neurological pathways or pathophysiology. But again, the critical point is there is no conscious deception involved. The source uses that classic example. The man presenting with flaccid leg paralysis who, when startled by a loud noise, suddenly leaped nimbly off the examination table. His paralysis was real to him in that moment, driven by psychological factors, not intentionally fabricated for gain. So the key clinical differentiator across all these is the positive confirmation of deception in factitious disorder.
Right, deception is the dividing line. Okay, let's talk about management. For the patient with factitious disorder imposed on self, what are the goals? It sounds incredibly difficult to treat.
It is very challenging. The primary goals are usually, 1, minimize morbidity. That means reducing unnecessary tests, procedures, hospitalizations. 2, address the underlying psychopathology, the personality issues, the coping deficits. And 3, manage the legal and ethical risks involved for everyone.
And this must be highly taxing for the hospital staff, dealing with this day in and day out.
Oh, absolutely. One of the highest clinical priorities, honestly, is managing countertransference.
Countertransference.
Yeah.
The staff's emotional reaction to the patient.
Exactly. That intense personal anger, frustration, maybe even hatred that clinical staff can feel toward a patient they know is actively deceiving them, potentially harming themselves, and consuming huge resources. It's essential for staff to attend interdisciplinary meetings, case conferences, to process these really powerful feelings. Otherwise, that anger can easily lead to avoidance of the patient or maybe punitive or inappropriate care, which paradoxically just increases the patient's morbidity.
That makes sense. You have to manage the team's reaction to manage the patient effectively. And the actual treatment strategy for the fictitious patient themselves.
Yeah.
You mentioned it has to be non-confrontational. Why is directly confronting them so harmful?
Because direct confrontation typically achieves nothing positive. It almost always destroys any chance of a therapeutic relationship. The patient feels exposed, shamed, attacked. So what do? They usually leave the hospital abruptly, often against medical advice, which just allows them to save face in their own mind, and then, well, start the whole cycle of deception over again at a new hospital, often escalating the danger.
So confrontation backfires. The goal then is to allow the patient to retain some control, but shift the motivation away from self-harm.
Precisely. You want to create a situation where they can back down without feeling completely defeated or exposed.
And this is where those clever behavioral strategies come in, like the double-bind technique.
Yes, the double bind is a crucial face-saving technique described in the source. Works like this. The clinician tells the patient something along the lines of, okay, if this symptom is genuinely physical, the treatment we're providing should work. However, they might continue, if the symptom doesn't improve with this treatment, it suggests that maybe it's not a typical physical problem. Maybe it's a different kind of condition, perhaps related to stress, something that you actually have some control over, maybe through techniques like self-hypnosis, biofeedback, or relaxation training.
Ah, so you're giving them an out.
Exactly. It reframes the situation. It shifts the internal narrative. It gives the patient a path to recovery that they can control themselves without having to confess the deception. They can essentially choose to get better using these alternative methods rather than feeling forced to escalate their symptoms to maintain control or prove the doctor wrong.
That's quite sophisticated psychologically. Okay, finally, let's turn to management for factitious disorder imposed on another. This raises the absolute greatest ethical concerns, doesn't it?
Without a doubt.
Given the frighteningly high mortality rate you mentioned, estimated between 6% and 22% for victims, and the alarmingly high risk to any siblings, sometimes up to 29% risk of death for them too. Why is it stressed so heavily that victim protection must be the absolute first priority?
Because the perpetrator's underlying pathology makes the victim, usually a helpless child, an immediate target of potential or actual lethal harm. Safety simply has to be paramount, above all else. This means mandatory reporting to Child Protective Services or Adult Protective Services, depending on the victim. It's legally required, regardless of any therapeutic relationship the clinician might feel they have with the perpetrator.
No wiggle room there.
None, and it often necessitates the immediate removal of the dependent child or adult from the perpetrator's care until their safety can be definitively assured, often through court intervention. It's drastic, but the risk is just too high.
Understood. Okay, so wrapping this up, what does this all mean for you, the listener? We've covered this really severe spectrum of factitious disorder, haven't we? From the peregrinating Munchausen patient seeking control through drama, all the way to the caregiver, causing fatal harm to a dependent.
Yeah.
It's a diagnosis that is fundamentally built on deception, yet as we've explored, it seems to reflect profound, genuine psychiatric suffering. It seems rooted in these complex, unmet needs for identity, for control, for attachment, however distorted.
And maybe a concluding thought for you, the learner, from this chapter. It can be helpful to conceptualize deception itself on a kind of continuum. Think about it ranging from, say, normal coping mechanisms we all use sometimes to minimize criticism or stress, all the way up to the severe, chronic, life-threatening pathology of Munchausen syndrome.
Why is that continuum helpful?
Because seeing it that way helps clinicians, and maybe all of us, avoid therapeutic nihilism, just giving up on these patients. It helps us recognize that even the most baffling and frustrating deceptive behavior stems from deep, often trauma-based psychological needs. Needs that can perhaps sometimes be redirected and treated, even if a full confession of the fabrication is never actually achieved.
A really important perspective to hold on to.
That's all.
Well, thank you for joining us for this deep dive into the very complex world of factitious disorders.
Glad we could unpack it a bit.
Remember to keep learning.